Good morning and welcome from Berlin. I'm Joanna Hannefeld. I'm the head of the Center for International Health Protection at the Robert Koch Institute. I'm also an associate professor for health policy and systems at the London School of Hygiene and Tropical Medicine and the lead of its Berlin office. It's my great pleasure to welcome you to this panel on Germany's role in interdisciplinary and cross-sectoral global health research. This panel is organized by the German Alliance for Global Health Research, GLORA, a platform which was set up about 2 years ago with the support by Germany's Ministry of Science and Education to foster interdisciplinary research in global health. And GLORA as a group, we've grown very nicely. So we had the opportunity to meet 2 days ago here in the Cosmos, about 150 researchers, but we've grown to around 700 people in Germany. And while we're still at the beginning, it's very clear that in Germany, certainly interdisciplinary research for global health is really sort of a field in its formation and developing. So today we're going to discuss a little bit lessons learned. We're going to discuss some of the challenges, and we will do so by focusing on interdisciplinarity in addressing neglected tropical diseases. We have an excellent panel of people. We're delighted to have one of our panelists here. The other ones are joining us online from a range of disciplines. We've got participants from academia, we've got participants from product development and from the WHO. So I very much look forward to today's discussion. And it's with my great pleasure that I introduce the co-chair of today's panel. And in true GLORA tradition, this is a biomedical scientist, Professor Jürgen May, the director of the Bernhard Nocht Institute for Tropical Medicine in Hamburg. Also, like myself, a member of the GLORA steering committee. Jürgen, the floor is yours.
Yeah, thank you, Johanna. And good morning also from my side to everybody. It's a pleasure for me to introduce the first speaker, Dr. Gary Aslanian, who is the current manager for partnerships and governance at TDR. This is a WHO special program on tropical disease research, which is instrumental since decades for interdisciplinary research on poverty and neglected tropical diseases in many countries all over the world. Thank you, Gary, for joining this meeting. And we are looking forward to your view on interdisciplinarity and your experiences from the WHO and TDR side.
Right, great, and good morning and greetings from Geneva. So I just have one slide, and I'll keep two very brief comments. Obviously, it's hard to cover everything in a brief presentation, but I hope to give you a sense how we've been working at TDR on this and then engage in further discussion. So you've already mentioned that interdisciplinary and cross-sector and more implementation research is now main focus of what TDR is doing. But obviously over the 45-year history, we've done things including in products and trials, etc. But I think in the last strategy, it became clear, and with the help of Germany, who is part of our board and institutions and government from Germany, that we should focus more on implementation research. So mainly, again, the reason for this is that the challenges to achieving universal health coverage are there, and progress on NTDs and malaria and TB is slow and maybe perhaps even falling as we speak. Therefore, implementation research and public health kind of research needs to support that. So that's where we're focusing at the moment. And this is great that your panel is going to unpack this, and TDR has benefited from a wide range of collaborations with German institutions that this can be further discussed. So as I mentioned, the barriers to implementation of interventions that we know and have remain, and they're not going anywhere. And these are exacerbated by COVID pandemic. So we have some examples already. You've had a report on TB, for example, last week or so around the fall in our efforts in achieving TB-free world, so to say. And obviously COVID has not helped with that. We worked with several networks in West Africa that focus on TB, for example, and clearly COVID and the COVID and TB have become an issue there. So we are working on making sure that these networks are supported and networked together. So in terms of approach, and this is just kind of to share how we do it, and obviously other panelists will also share their approaches. What we actually do is that in any of the calls, we're a research program that we have calls, we have research calls, we also have prioritization processes when we identify where to go and where the best way to bring different stakeholders, and as well as capacity building. Our main process is to engage different partners in that to achieve that interdisciplinarity and sector overlap in way that we approach any of the calls. And this calls actually ask for that. So there is absolutely always a requirement to have engagement of various sectors or parts of the system, or having both academic and policymakers within a team, and that's part and parcel of these approaches. So another obviously important aspect here, and this is increasingly something TDR has been doing, I can't say that's been always doing, and it's not that easy, is the inclusion of implementers and people actually who work in public health, who need their answers in the system, in a very short term, quickly. So we work with that to make sure that they're engaged. And we have increased focus on gender and gender issues and considerations in all of the work that we do. So this is increasingly clear that these need to be considered from the get-go by design in terms of, and this is not only for women, but also for men, depending on a disease and depending on the neglected area. Another area we focused on is social innovation and research around social innovation, because a lot of innovation is done, but not researched. So we do need to support that the evidence from the social innovation is clear and can be replicated in other parts. So we have different ways how we do it. I'm not going to have time to go into it, but it's grants, it's a specific sorted approach that we have with operational research. We have networks, we have One Health teams that work with animal and health vector issues, and as well as engaging with regulatory authorities and research around regulatory approaches when it comes to access. Country capacity, and not just of the researchers, but also health implementers who are doing research and using existing data is increasingly an area where TDR has increased its focus, just because the questions in the system are raised by those in the system, and research can only help in answering those questions. Overall, you may have heard, obviously, this term of learning and resilient health systems. So in countries, our hope, and I'm looking forward to discussing this with other panelists, is that any production, use, and capacity around evidence within that learning system is part and parcel of that system, and is contributing to achieving those really unmet needs when it comes to equity, when it comes to NTD elimination, etc. So I'll stop here and pass on back to other panelists, and looking forward to further discussion.
Thank you very much, Gary, and thank you very much to keep in time. After the impulse talks, we have a few minutes for questions from the auditorium. And for those sitting in front of the screens, please send us questions and I collect them here, and then I will read them and ask the panelists for the answers. We change now to a more academic view. And the next speaker is Professor Praceres da Costa. Clarissa is co-director of the Center for Global Health and principal investigator for parasite immunology at the Technical University of Munich. And she is a medical doctor by training and has a research focus on immunology of schistosomiasis and other parasitic infections. Thank you for being here, Clarissa.
Thank you very much, Jürgen and Johanna, for inviting me. And of course, thanks to Laura and all the other panelists and the audience for being there and listening. So I will just share my screen. Yes, okay. So as Jürgen already mentioned, my role here is to represent the academic viewpoint of how we can, foster interdisciplinary research and then represent the life science point of view. And have taken the freedom to have 2 slides because I think there's still a lot of challenges out there for sure, but also opportunities. And for sure, we're going to discuss them later on in the panel session. And so in general, of course, it's clear that the goal of academia is good education and to generate young people with reflexive and in the end also synthesized minds. And I think here already and the viewpoint of academic global health, it's clear that we need new approaches because we are still organized in disciplines, of course, and interdisciplinary research needs new approaches. And this is an ongoing discussion we can also deepen later on. But in general, there's also a general lack of global health engagement. And I think this overview generated by Sabine Gabrisch and Thomas Jähn 2 years back reflects this really nicely. This is a landscape of global health professorships, which have global health as one research topic at least in Germany. And you see them, if you compare them to other universities like the Johns Hopkins or the Harvard Medical School, Swiss Tropical, Germany is still lacking behind, but this is sort of nothing new, but it's a challenge in the end. Also, there's a poor connection between the sectors and disciplines in general, especially between the social and the life sciences. There's new ideas how to foster this in terms of centers, so research centers which under their umbrella have disciplines together, but there's still the connection, I would say, is still poor. Also, at the same line, actually, we also see a fragmentation in funding and funding program landscape. So different funders are not aligned, which of course then is a problem. If you start with a life science, from a life science point of view, with an NTD research, for example, topic, you need to generate long-term perspectives. And if programs are not aligned, it will be difficult to find further funding. And one other point that always intrigues me is that most of the interdisciplinary projects require this long-term perspective, like I said, but also the willingness in the end to dedicate time and effort into these activities. And these are activities that are tedious, of course, and they are sometimes outside of your direct research topic. And this is something that also needs to be incorporated into the design of these approaches. And that also means that it's sometimes difficult to find and incentivize academics to really take up such roles. For sure, there are more challenges that we can discuss later on, but let's come briefly to opportunities. And outlook. And I have, unfortunately, Ulrike Meissel, who was to be my social science academic partner, is not on the panel today due to sickness, but I stole this first viewpoint in terms of also opportunity or outlook from her. So what we need in academic NTD research is basically to generate a biosocial understanding of NTDs. And once we've have that platform, it's easier then to progress, of course. And so what could be the opportunities or solutions? Engagement and teaching. Of course, one of our main goals is to teach young generations, and that's what means we need to integrate global health and NTD research into the curriculum level, teach courses, interdisciplinary courses, reach out to WHO, generate opportunities. But also enhance exchange on institutional levels and also on academic society levels. So north-south alignment of academic societies, so meetings of these societies could be fostered, for example. Also the alignment of funding agendas and program landscape among the funding agencies, but also the ministries. As you know, we have different ministries, but that all engage in global health, but sometimes there might be a mismatch in alignment, which could then be fostered if once we align, would foster our agendas better. Like I said, the willingness to dedicate time and effort, how can we generate opportunities? And I think here definitely GLORA comes in because it really tries to transition from disease focus to more comprehensive programs, which we need also in NTD research. We also have, of course, the BMBF Sub-Saharan African Health Networks, for example, and even the German Research Foundation, which has a program on collaboration between Germany and Africa in infectology. Finally, we need to incentivize, of course, our young generation. We need to generate opportunities, for example, in interdisciplinary research for publications of these interdisciplinary research, also in higher ranking journals. We need new career programs, for example, that really are based on interdisciplinary research. So with this, I would like to finish and thank you. This is my last slide.
Yeah, thank you very much, Clarissa, for this overview from your side. And I'm very happy to introduce the next speaker. This is also an academic view. And yeah, I'm very happy that you are here. It is interesting to see that the speaker with the longest travel distance could make it today. The next speaker is Professor Enrique Barros. He is the director of the Institute of Public Health of the University Porto, and he is also engaged in many fields of global health. And we will hear about his view on experiences and challenges of interdisciplinary work in public and global health.
So thank you very much for your invitation. It's really a pleasure to be here with you after all these months. I think we already listened to so many relevant aspects. So allow me to go to something that is a little bit of the basics, and to remember you that public health is organized effort of societies to promote health, to prevent disease, and to help people to get back to a full active life. So if we take this definition and what it implies, maybe it's acceptable to imagine that you can organize research in public health and in the allied sciences. I'm an epidemiologist, so maybe I'm biased towards this type of problems. We can see it as academic research, as operational research, a special sort of operational research that has been already cited, that is implementation research, and advocacy. I think advocacy is a major area in public health, especially when you think about neglected and poverty diseases. And it cannot be just willingness or something unprepared. There's a science behind the advocacy that we need to look at it with carefully. And I would say that implementation and advocacy are probably the most relevant in this context, if we want to really translate the knowledge that we are producing in other areas and brought from different allied sciences into effective changes in people's lives. The second point is the need to couple these research and different research trajectories with formal training. And academia is obviously important for that. The topics that are behind the objectives and the aims of public health should be carefully organized by the schools and departments of public health in all different regions, not only in those more concerned with these topics. I think there is an imbalance in all this. We know we have this well-known 9 to 1, 90% of the money goes to 10% of the problems in terms of health. But I think that we need a clear training, as we saw in public health, in global public health, even in the understanding of diseases of poverty, because there is also mobility in that. So we lack that training. We need more training, and we need to show people how relevant they are. And for that, we need to favor obvious multidisciplinary approach, but I would also add multi-professional approach. It's not only the discipline, it's also our backgrounds, our training, where we come from. Are we nurses, are we medical doctors, psychologists, life scientists, sociologists, anthropologists? They are very relevant and not that present as they should. And we need surely to have a competencies-based education at all levels of education, graduation, if you want. But I would remember the need, and I think there's much, there is a real lack, and so we need more efforts in guaranteeing lifelong education regarding these topics. It's even for clinicians, it's difficult to diagnose some of these problems when you are not close to them in your daily life. The third point has to do with what we can call health literacy. We need to think about health literacy and relate it to the needs of people, to the identified gaps. But we need to do it with people, with communities participating in definition of what is relevant, making a sort of a hierarchy of problems. And we need to negotiate with people which are those most relevant to tackle in each community, in each situation, because it's we still have we talk about it, but I think we don't take it as seriously as we need. This sort of unbalanced power between those who are able to help to solve the problems and those that have the problems, and often they are not helped in the way they need. So it means that we need to have a multi-layer approach, a continued attention to social injustice, to inequalities at all levels of the social, economic, and political organization, because they are essential if you want to implement the knowledge you have to change things. Another point is to have a really global health view and approach to this, and not even using these words being very, very too narrow to focus on what we are looking at and losing the whole picture. So it's very important to bring as many stakeholders as possible. If you look at the planet of we all as countries, maybe we need to put more emphasis on collaboration than in cooperation, and to promote the so-called South-South collaborations, because it will help to empower people, and in the end to contribute to this sort of decolonization of knowledge and solutions. But especially it's relevant to put the idea of social determinants of health in the front line. Because in the end, as we often say, where is the point in sending people back to the conditions that contributed or the cause of their diseases? Even if we try to treat them, to help them, if they go back to the same conditions, to the same system, ecosystem, they will get the problem again. And what we are probably just promoting very often is as we saw with soil transmitted elements, is if there is a lot of drug pressure, we are increasing resistance and we are decreasing our ability to cope with it in the future. So finally, you know, public health is not a science, it's a bundle of science, it's an art of solving problems, taking the community of our interest, like clinical medicine, when you look at an individual. So to guarantee that all this makes sense, we need to really have a clear funding for the sciences of public health and for putting it into practice as we build hospitals and healthcare centers and structures to diagnose and treat people's problems. We need to do the same. We need the structures devoted to public health, so that are able to survey the situations, to adapt to the transformation of the situations, so that in the end we can bring together the social, the economic, the biological, the psychological, all the aspects that are involved in getting disease or solving it. Thank you.
So much, Enrique Barros, thank you so much. And at this point, it would have been my great pleasure to introduce Uli Beisel, who would have been here in person, unfortunately had to pull out. I believe there is a slide, though, that Uli wanted to share. So Uli Beisel is an anthropologist who currently holds the chair for human geography at the Free University here in Berlin. Again, she was unable to join, but I had been told that we could share the slide. Don't know if that's possible. Can you give me a thumbs up or a thumbs down? Thumbs up, okay. Because it's not clear whether it's a thumbs up or a thumbs down. So, okay, good. Okay, so Oli wanted to make an intervention. So she's obviously from an academic discipline, academic background as well, a social scientist working very much on challenges in global health. And she had 2 points, next slide, please, that she wanted to bring here. And I think the first one was very nicely already mentioned by Clarissa. Next slide, please. Was around the fact that when we talk about neglected tropical diseases, she was citing a colleague, another anthropologist, Melissa Parker, saying that the neglected itself is a social category that has been constructed in a way to relatively successfully, actually, if you're honest, to raise funding, to present something as an issue, and to raise it on the political agenda. But the point to make from that body of research that Uli was presenting is really that biomedical interventions are never just technical or pharmaceutical. So quite often you say, oh, this is the pure science, but that many social factors actually determine whether something is implemented, carried out, whether the effectiveness is reduced, or a target is achieved. And that really we need to have interdisciplinary work when we think about neglected tropical diseases, not just really from the starting point of how this is constructed and perceived, but also by including target populations from the beginning in the agenda setting and in the design of such interventions. If we actually want to address an issue, if we want to address a disease and its health consequences. And the second point, and that is echoing some of the comments just made by Professor Barros, is around the trend that is currently happening in our field. So I think we all know global health is maturing as a field of research, practice, and policy, and the movement to decolonize this is sort of very powerful. Is certainly is a debate that's very alive in the academy today. And this work around decolonizing or critically reflecting on the origins of global health, where sort of in many instances, I guess, rich institutions in the North, as part of their colonial history or as part of their colonial histories, investigated something in the global South, and certain power dynamics were set up and as a consequence reproduced in our discipline, that the inquiries that are happening around decolonizing global health are by their very nature interdisciplinary. So the debate around cross-sectoral research and interdisciplinary research that focuses on power, that focuses on partnerships, that sort of critically examines what we do in our practice, be it around neglected tropical diseases, around poverty-related diseases, but this inherent reflection on the practice of our research and academic work, very much by its nature is interdisciplinary. So I think she wanted to, well, I'm paraphrasing, I hope I'm not speaking out of turn for her, but I think she wanted to sort of say that interdisciplinary is growing on the back of that, and that networks such as GLORA in the German context, but there are others, are obviously a vitally important platforms to bring together scholars from these different disciplines as we grapple with bringing the field into the next generation, or sort of maturing it. So that was the input that Professor Uli Beisel wanted to give around that. Thank you very much. I think if you end the slides now. So then with that, it's my great pleasure to introduce the next speaker, who is not here in person, but I'm delighted to see her on the screen in front of me. Dr. Nathalie Strup-Voergaft is the Director of Neglected Tropical Diseases at the DNDI, which seeks to develop new treatments for neglected diseases. And I think really some very practical experience, and again, a totally different sector. So really interested to hear about your perspective. And over to you, Nathalie.
Thank you so much for the invitation. It's a pleasure to be here, and in fact to come after what I have heard, which is really totally aligned with our views at DNDI. So I have just one slide, if it were. So this slide is a bit busy, I'm sorry, but it's showing on the left what we're trying to achieve, but on the right how all of this is integrated and should be integrated with the SDG goals that we're trying to come towards. So maybe to give a bit of background, DNDI is a not-for-profit R&D organization. We were founded in 2003 with public research institutions of countries already affected by some of the NTDs, such as KEMRI, ICMR, Fiocruz, or the Malaysia Ministry of Health. We have TDR in our board of directors, MSF, and Institut Pasteur. And this was done because we wanted to address the needs of patients suffering from neglected tropical diseases, which we extended later on to neglected populations. So NTDs are typically multifaceted. They affect poor populations, often living in remote areas, stigmatized by their disease that carry a very severe mortality burden. But patients are voiceless. They have no big community, advocacy communities. The diseases were initially considered not to travel much, and leaving those groups quite isolated, and for which very little research has been done, as they did not and still do not represent a powerful economic community. They have been neglected by the pharmaceutical industry research, so that we are still missing diagnostic and field-adapted treatment approaches for many of them. In fact, still 1 billion, half being children, are affected by NTDs, so it's really large. NTDs are described as entertaining a vicious cycle of poverty. Oops, sorry, I have a little bug here. a vicious cycle of poverty. In fact, poor living conditions, including lack of safe water and sanitation, increase the risk of infection. Living in remote areas will result in lack of early access to care, but the later they are diagnosed, the higher the risk of less favorable outcome. For some, treatment is done through chemoprophylaxis campaigns, but for others, for other NTDs, treatment is often administered in specialized secondary or tertiary healthcare centers so that patients need to reach them, will thus come late, often after first seeking care with their local traditional healers. Mothers will come with their children. They will sometimes travel by foot for a few days, and once diagnosed and hospitalized, will still have to pay for their food as well as food for their accompanying family. They may have to pay for lab exams and usually for hospital stay. All this puts the entire household into more poverty. School or work days are missed. The socio-economic impact is huge, and this vicious cycle continues. Finally, patients with skin diseases like CL or PKDL or borreliose or mycetoma are often stigmatized, but also patients with sleeping sickness, for example, and their families. So the mental health impact is very important, but often underdiagnosed. And of course, no treatment is anyhow accessible for that. So we need cross-sectional approaches to understand the epidemiology, the transmission, the role of the animal reservoir. We need to model the impact of any strategy and identify the last case. We need to approach those diseases in the context of One Health. And this is, I think, a growing approach that everybody is interested in. NTDs are said to be a litmus test for universal health coverage. And all this collaborative multi-sectoral approach should promote access to better care and reduce the financial burden that NTDs impose on communities. And the WHO NTD roadmap provides direction in support of these 2030 SDGs. So what are the impact and the difficulties? At DNDI, we developed 9 treatments and are on our way to find another plus or minus 10 within the next 8 years, together with fostering inclusive and sustainable solutions, as well as continuing to advocate for change. If we look at R&D, the challenges are still multiple. First, and it was mentioned earlier, is to develop a target product profile, which is qualifying the need from the field as well as the healthcare context in which implementation should happen. And that needs to be done with the key local stakeholders. And I'd like to note that oftentimes NTD patients or their communities are not organized as groups. So we work with their healthcare providers, but they are not in the middle there. This also comes with understanding the need for the most vulnerable populations, such as children or young women, which comes with additional R&D considerations. So we also must define storage conditions, route of administration, and cost that will all impact upstream R&D. And this is why we do this very early in the development. The second big challenge relevant to today's discussion is also to identify very early on the scientific partners and competencies that will bring each of them their unique contribution to sustainable test and treat strategies, which is what we want. And this is a big topic, so we may come to this a bit later. We need to define and identify a committed industrial partner. We need to continue to advocate for the need to fund R&D for NTDs and for poverty-related diseases, but we also need to advocate to fund sustainable and affordable manufacturing, procurement, and distribution, and in fact, even to finance this. We need to ensure that regulatory and PV systems have the capacity to regulate the new tools and the follow-up of new products distribution. Lastly, and this is again very relevant to today, we need new partners to complement what R&D alone cannot do, which is to understand the mental health, nutrition conditions, water sanitation and hygiene, and as well as more social sciences like we did recently in the case of sleeping sickness. There are opportunities. PDPs and engaged tropical medicines institutions already work together. That's the case with, for example, with Bonn and with Bernard Nock Institute. We have clinical trial platforms which do bring together the local health providers, doctors, nurses, lab technicians, academic policymakers, NGOs, other PDPs, regulators that help to define first the target product profile, but do a lot of training on many aspects related to clinical research and later to prepare for access. And that's a big collaborative mode, which is quite successful. We have partnerships with the industry, of course, to feed the pipeline, but also to develop and promote and start access. That's already, of course, it's part of our model. In Germany, we have a partnership with Bayer, and we're working now on launching the trial in Ghana with one of the drugs that comes from animal health. We have collaboration with other PDPs, for example, with FINE for diagnostics, but we need more. We definitely need more. And we need to bring new collaborations on artificial intelligence, which is here and starting. And finally, we need joint advocacy, and we have done joint advocacy with various NTD networks where Germany is quite active to support all these messages. So maybe I'll stop here for now and wait for the continuation. Thank you.
Thank you so much, Natalie, for a fascinating presentation. I think over to you, Jürgen. We'll see whether we have some questions.
Yeah. Thank you all the speakers for the impulse statements, which will be the basis for our discussion. Now we have a few minutes for one or two questions. I don't see any questions in the chat, but maybe here's one in the auditorium. Yeah, Daniela.
Hi, I'm Daniela Fusco from the BNI, and thanks a lot for all the interesting information. I have two comments, and one is for Professor Barros and Clarissa. I was very interested to the definition of Professor Barros as public health as an art of solving problem and not a science. I really enjoyed this definition. And I was really interested from the comment of Clarissa saying that we should push global health toward, for example, incentivizing high-ranking publication. While from your point of view, you were saying we should understand weapons, we should be multisectoral and be more in the world, which I really think that is a key for global health. So I'm wondering, shouldn't maybe have a less basic science approach toward global health in order to really get our target and meet our needs. And when it's about colonization, also I was very interested in what you were saying, decolonizing global health, which is a super interesting topic and very important. And I also think that probably we should start thinking global more than north to south, and also what south to north can give. In these days, we have heard a lot of very interesting initiatives in low and middle income countries from where the north can learn a lot. But we don't have still this perspective because we still think of north-south collaboration instead of thinking of global. And so probably this could be very interesting to think and look forward. Thanks a lot.
Thank you. And we have time for one last question.
Walter Bruchhausen from Bonn University and one of the GLORA speakers trio. Yeah, I'm really glad that all these views, these perspectives, these demands that we have heard, and probably nobody here in the room and in front of the screens would oppose. But my question is really, why so late, especially in Germany? Yeah. So we have started to work on colonialism in healthcare in the 1990s, and we were told, well, that's something for historians, not for health experts. We have asked for biosocial approaches for 20 years, and it's now taken up as a new thing in Germany. Global health education we started 10 years ago, and why is it that late? And one answer I could give is really something about the structure of the institutions within academia. I looked in the establishment of such new disciplines as medical psychology, medical sociology in the 1970s. And it was taken up immediately after there were the proposals for reform, despite a lot of scientific opposition, but the social need, the political will was there. Today, if you want to establish something like global health, you have to get funding for 5 or 10 millions before a faculty would accept that you are a new important field. Yeah, and that's yeah, it's really the result of a kind of neoliberal thought, commercialization, and competition within academia that is really hostile towards these kind of social arts and enterprises that you've described here. And therefore, I think it's not just a thing that we can continue within the ordinary structures of academia, but we really have to find new ways, for example, of collaboration between yeah, the governments and academia. And we try it in Bonn now by regular consultations with GIZ, which is the agency of BMZ. Once a month, we meet from the academic side with the people of the implementing side and have a fruitful exchange. And I think these are important steps to overcome yeah, the silos that has been a lot of talks on now here at the World Health Summit and before. And yeah, that's the direction we have to go. Thanks.
Thank you very much for these comments, and we have to proceed. And hopefully we have a bit time at the end of this panel discussion.
But should we put the question to Clarissa that was asked? I don't know, Clarissa, whether you want to come back on the question of the basic sciences and maybe.
No, absolutely. If it's possible to do that now, we can. Then definitely, I would answer. Daniela, I mean, absolutely. And so I would say basic/life sciences first of all, very clearly. And I think, from the education perspective and perspective of supervising masters, students, PhDs, as in the academic landscape, it's still expected that there you have to have a spin-off of a certain disciplinary depth. That's what I said in the beginning. And I think it's still a challenge, and but also then sufficient coherence between the different aspects that you want to incorporate. So, and I think, and like, we will not be able to change, you know, academic requirements now, but we need to definitely put the problem out there, right, and discuss the problem. Very concretely, you will not be able to have your PhD or obtain his PhD in the end if he or she does not publish accordingly. But I don't, and the next comment that I would then put out is that, of course, not only basic science publishes highly, I mean, public health publishes highly as well, as does any kind of other science, for sure. So I wouldn't be that basic science or life science focused. And also, I mean, I think what the COVID-19 pandemic has definitely taught us, I mean, that there is, of course, the contribution of now from the field I'm working in, immunology, for example, or coming from the translational side to vaccine development. But we all know that's not the end of the story. Looking at the problems that we are now having with vaccine rollout, which is definitely a major public health challenge, right? So, yeah.
Okay, so I think important point that even if we work in an interdisciplinary way, we do strive for excellence in our academic research. I think that's what I'm going to take from that. I'm conscious that I'm sort of with the time, so I'm going to move to the next question and bring Gary back in. So we've heard a lot about the opportunities and also the challenges and also the opportunities in terms of working in an interdisciplinary way. So, but how do we facilitate this collaboration in the different sectors that we've heard from? So at WHO, you mentioned some of the aspects, Gary, but how do you bring together different sectors to collaborate around NTDs for research and for the control?
Right, thank you. Clearly, there are many examples, and I can, let's say, if we pick one wherein we involved climate change and, let's say, sleeping sickness in, Masai steppe in Tanzania. So here you have so many players. You have to involve people who work in agriculture. You have to involve the Maasai people and herders. You have to involve the people who are doing research, let's say in this case in Tanzania, in various parts of the research system, the National Institute of Medical Research, and then universities that are doing work there. Then you have to involve the water and other sanitation people. And then climate change obviously is changing the patterns. So this research is one example where while it's a neglected tropical disease and we have solutions with the change in climate change and the changes in patterns and how, let's say, Maasai people move around with their, doing their cattle herding, all of these sectors have to be involved. So in this research over several years, the researchers work with the community, work with the animal health side, worked with the the water and sanitation part of the system to understand the patterns. How did climate change affect really the transmission of this disease? Even if we obviously will have a solution and we have ways to prevent it, but we have to know how does climate change affect it. So just one quick example to help you put into perspective how we worked with various partners, and university in Tanzania in this case obviously led this effort and engaged various researchers in that process. So I don't know if you want more. I'm happy to add more from other parts of. Yeah, please.
I'm gonna go to Enrique Barros here in the room. So Enrique, from your perspective, again, in academia, but in your institute, how do you facilitate? How do you actually get the sectors to work together? And you went beyond disciplines. You said we need to work with all the different sectors, covering all the different social determinants. So how do we do that? How do we facilitate that kind of engagement?
Yeah, but let me begin by saying that, of course, what you look for is, well, to use a word that might not be, it's too often used, but I think it makes sense to look for excellence in what we do. So bringing new things and doing it in a very clear, high quality way. So whatever the discipline you are looking, but in fact, there is a sort of an interface or different interfaces between disciplines that looking back to all these years I've been working, we seem a little bit unable to solve this situation, because when you work in these interspaces, you seem that you don't belong to no one. And it makes life very difficult in academia, in the real world, and because you are seen always as a kind of a stranger to the other. There was a joke. I began as a medical doctor. I was a clinician, and there was a joke saying that an epidemiologist was a mathematician for a medical doctor, and a medical doctor for a mathematician. So I think this quite nicely summarizes the problems we face. So we need to create this community of people working in between disciplines, and we are, to a certain extent, we are building the bridges, and so it takes time to make it recognized. But that's the way we try to do it. It's putting people together. That's why I call the attention to training, because it's where you can begin this sort of cooperation and understanding the role of different people, the different contributions. So I think that schools of public health, but also professional schools, medical schools, nursing, nutrition, psychology are essential to help to change this. That will take a lot of time. For instance, we are now part of a consortium of universities from Germany, Portugal, France, Hungary, and Sweden, that we make an agreement around global health, and even that it's difficult, because the way we see global health, it's different if I'm someone dealing with artificial intelligence or designing medical devices or doing field work in public health. So again, that's something we need to build. It's a journey. It's not a destination, I'd say.
Thank you. And I mean, many sort of practical questions. I think we've already heard around the training programs that are beginning now in global health. Are they situated in the medical school, or are they situated in the schools of sociology or anthropology and so on? So some very practical questions, I think. But thank you for those inputs. I'm going to come to Natalie next, and I'm going to ask you in terms of interdisciplinary collaboration to develop new products. So from the examples you gave, I think it was very vivid already, some of the challenges where you do need the different disciplines. But from your experience, how do you get the different disciplines to work together to meet your needs? And you've got a very concrete need, haven't you? I mean, you're developing a product. So how, in your experience, how does that work?
Well, thank you. It's a tough question, but I would say it's having the same vision. We start by having the same vision. So our partners want the same thing. And we all understand that, as people say, no one can do it alone. So we have to agree on finding the complementarity between all of us. We like saying that DNDI acts like a director of a virtual orchestra. And the thing is to make beautiful music, you need to have the right artists, and we find them, and they all want to play the same music, and I think that's how we do it. So of course it's not simple. It's not we are struggling to get in fact we're struggling to get funding for good science. That's a major problem, but we have groups who know, for example, a parasite. They know how the parasite evolves, they know how to see it, to measure it, to track it. So we work with them. We need to have good pharmacologists. We need to have good modelers who can help us to do PK, PD modeling. We need the scientists to help us to do animal models. And recently with COVID, we saw when we started, we had no solid animal models. We now have better models. So we need to work with academics groups that can help us to do that. We need manufacturing CROs, or we need the industry and or CROs to help us to develop a pill that will be absorbable, and we need to understand how to do that. And then, of course, at the field level, but that's maybe the less difficult, we have the clinicians. They are doing all the work on clinical development. They are the ones that will develop and construct the TPP. Which is essential, again, because they will define the priorities, and we listen to them, and we just bring the tools that they will then implement and study and implement. We need partnerships as well with regulators. Nothing is simple when you develop for NTD because it's not been done before. So you need this collaboration as well between regulators, and we need more, I think, collaboration, not yet there, as I said, with social scientists. That's really missing, and with diagnostic groups, because it's not only about having a test, which is essential to test and treat, and we don't have this, but it's also to have markers of cure that are missing in many of those diseases. So you can see a wide range. I could continue, but I think the key thing is we have, I think we have the right people wanting to do the same thing together, and we have funders who understand what we are doing, and what is key also is to have funders who accept to give us funding for our program, so that we can have some errors and continue to have funding, because science is not so simple. I'll stop here.
Okay, so a shared vision. Thank you very much. And Clarissa, I'm going to come to you last but not least. You're a medical doctor. You introduced yourself. You do interdisciplinary research in global health, and you sit at a technical university in Munich. So how do you facilitate this interdisciplinarity from your positionality, from where you sit specifically? What's your experience there? How can we bring people together best?
Yeah, thank you, Johanna. That's a good question, and I think so. So what we have done at Technical University, so Andrea Winkler, my colleague and friend, and I, we have instituted a Center for Global Health. We funded this center, and with the clear vision to foster interdisciplinary research, but first of all, I mean, the first obstacle is to clarify and the term global health, and to make this known actually in a community or in a technical university community. And there are a few people that clearly do global health research even without knowing it in the end, because they don't align themselves, for example, architects or other disciplines that don't align themselves really to this topic. So, so yes, centers, for example, as networking platforms to facilitate interdisciplinary research. This is what we have done at the Technical University. We're still situated at the medical faculty, one has to say, even though the broader perspective and would definitely be to become more centralized for sure. And but I just wanted to refer briefly back to the comment of Walter Bruchhausen, which I think is extremely important. What he said, you know, these there are always life cycles in science. 30 years life science, 30 years of approximately 30 years, and as you said, many things have been introduced already, even 20 years before. So I would just sort of call also a little bit to acknowledge that what we are generating here is something that needs to be taken up by the next generation, I think, and to acknowledge also that success might not be seen by us, but by our next generation. Even though we have to acknowledge definitely that there also, I totally agree about, I like this term neoliberal competition, but yeah, but if we think that is something that we don't want in the future, then we have to also invest time here. Yeah.
Okay, so we need time, and I'm just I have to interject that the slide in your presentation about the growth or the global health concentrations in Germany was, of course, before GLORA was founded. So we need to repeat that study and
yeah.
But back to you.
We would like to be a bit more concrete now. We are interested in what kind of investments and resources are needed to facilitate more interdisciplinary work in cross-sectoral collaboration for NTD research and control. One thing is clear and easy: more budget is always helpful and sometimes necessary, but for better work. But what else is needed? So beyond money, because this is easy. Gary, what is right. Your idea, or the idea of TDR WHO?
Sure. So to be honest, when it comes to money and or budgets, and again, I do not want to simplify this, but to answer a health issue question through an implementation research kind of design and engage, it doesn't need to be super expensive. We have small grants that have answered a system question in a ministry, in a public health department over a 12-month period and spend up to $20,000, and that issue's been dealt with in there. So from the point of view of an implementer, and again, this is assuming all the commodities are there, you know, the drugs are there, the other things are there. But to answer a bottleneck question, to answer an issue within the system, to do it, you don't need huge amounts of money. Now, what else is needed, obviously, is good data and data collection kind of systems that exist. Because if you want to do something that answers a question that is on the mind of an implementer and a policymaker today, and they need a solution, one of the things you need to do is to use what is available. So in fact, through one of our programs, which is sorted, those in the system working in a public health system or in the control program of NTDs have actually reflected that when they started using their own data to answer a question in their own system, they realized that they need to actually change how the quality of data is being used, how they collect it and how they used it, etc. So that's another kind of part of this. Now, the other part that you really need in countries is capacity, and we have observed that we have increasingly, and again, country capacity, and the countries can work with networks, let's say the NTD program or researchers who work with NTD programs in countries could work with their partners in Germany or in other European countries, and it will be perfect to use that opportunity. But at times, that capacity doesn't exist in all countries. So you really need to integrate with research, and that implementation in interdisciplinary research, you need to combine both research and training, or otherwise what we say is no research without capacity or no capacity without research. So these are a couple of reactions to that question in terms of what we've observed and we're observing in various kind of approaches to implementation research.
Thank you. Enrique, what investments are needed beyond money?
Yeah, well, if there is will, something will happen. But I would say, I mean, I think we need to solve small problems and to begin somewhere. So looking at my role and what I can do, I think it's time for a group of universities or a group of schools come together, bringing people from different areas of the world and giving them the same relevance and making a new program where both more fundamental research and applied research or implementation, whatever you want to call it, could be together and try to I mean, there's not that much like that, you know. Things are really separated, and there is more competition than collaboration between universities and countries and so on. So if you want to solve or to help or to bring something to this problem, to a solution for this problem, I think consortia of structures interested in it with a new vision, with a new, I mean, sharing the vision, that's very important. But trying to do things in a different way, because if you continue to do things the same way we have done before, you'll have same results. So I think it's time to try to design something new. And I think it doesn't cost that much money. It's just organization and putting things in a different way. Like when you change the furniture in a room, you know, the room is same, things are the same, but probably the result will be different.
Thank you. Clarissa, many things have been mentioned already. Do you have more ideas?
Well, yeah, I think along the lines of what Enrique said, I really like that, of course, but maybe, and besides also centers and so on that I have mentioned, and university alliances, which are, you know, increasingly being established north-south, but also, you know, more south-south collaborations. I would just also like to mention that from the academic perspective now, again, you know, academics like definitions and so on, and we need to be also aware that, you know, there are now many new concepts and definitions out there, like global health, not new for us, of course, but new maybe for some other areas of research. And then we have One Health, we have planetary health. And that sometimes is confusing also, it leads to confusion in the academic world. So I just want to raise the awareness here that this is something we need to take up as well and integrate into our discussions. And lastly, I mean, again, integrating global health into current existing curricula is extremely challenging. If you just think about the medical curriculum in Germany, the reform that we are going to have in the future, hopefully very soon, has been ongoing for years, and it's extremely difficult, I can tell you this, to bring global health here on the agenda, because there is a lot of other aspects that need to be taken care of. So that means we also here, for example, in the medical world, need to still take global health on board in various aspects, and we have to align, even though the world is moving on to tropical medicine, because that is still something that is in the existing curricula. So we have to expand them. Yeah.
Thank you very much. And Natalie, what is the perspective in research and development, which is always also cost effective, or not cost needing? And so, but what else beyond money do you need?
We still need money. We don't have enough. So. But no, I think we need more collaboration with diagnostic groups, for example, and we really need, and the science there. I mean, there's so many bridges that we don't have no time, but so many. But we also need the funders to understand that there is value, in financing these collaborations together. We need to make sure that I think the priority setting is done with a strong participation of those who are the first victims of this and the countries that are going to manage this. So the role of country leaders and of scientific leaders from the countries where we are operating needs to be a bit brought up into the system. And I think it's really missing, and more needs to be done probably there. In terms of the access, when we think about access and when we think about funding and access, I think we need to understand who will fund procurement for NTD drugs. We don't have a global fund, so that's a big area of thinking that many groups are developing there. But we also need to make sure that public funding is linked with affordable access of the end product. Quite key, and this resonates with the whole COVID crisis. And then lastly, maybe, I'm sorry if it's going in all directions, but maybe also thinking that different ministries who are providing support to different sectors also have a way of understanding how they are themselves connecting and doing multidisciplinary support, so that at the end we do come something that's a bit more efficient and does have this holistic goal. That's it. I'll stop here. Thanks.
Good. So I'm just wondering, do we have any questions in the chat? Otherwise, I have a question I'd like to ask. There's several questions before I can ask one. Okay, so the gentleman in the front, and then the gentleman in the second row.
Good morning. My name is Casimiro Vizzini. I'm the Secretary General of the European University Alliance for Global Health. That was mentioned by Professor Barros. UGLO is the name. So I have a point of view that is that I've heard so many of you saying that in academia is so difficult to interdisciplinarity. Professor Barros mentioned being a foreigner for the mathematician and a foreigner for the physicians. But the point is that the old generation has to pass the baton to the next generation. You need to create a new generation that doesn't feel a stranger in the other field. So it's, of course, if you take people from different fields and you put together, they say, who are you? But if you train them since the beginning, and you have to make this, it's an effort it's just changing the mentality. You need to start from scratch. You need to start from the young generation. And when they will be professor, for them will be absolutely normal to work in interdisciplinary teams because they've been trained to be interdisciplinary. So for me, this is the first step. And then second, in terms of international cooperation, in my previous position, I was an expert in the natural science sector in UNESCO. And for example, UNESCO has never been mentioned as, I mean, everybody knows UNESCO for culture, the World Heritage, but no, there is education and science. I was responsible for a project, it was called Human Variant Project. It's the collection of data on human mutation related to disease. This is an enormous global health issue, non-communicable disease, but it's a Western world research field. So why there is no, I'm happy that there's someone from the WHO because I struggled to communicate with them when I was in UNESCO. There's no collaboration with UNEP or WHO or OECD. So also, and the academia and this institution, because if you want to put all together, you need the academics to work with international cooperation. If you want to have academics from Africa or Southeastern Asia, you need to work with the member states of this kind of organization. Otherwise, you will be in your Western bubble. Thank you.
Yeah, and good point. Also, we should have maybe tried harder for. I'm conscious of representation or lack of on this panel. So thank you for the perspective and also for the plea for young people, for the next generation. But please, if you could introduce yourself as well.
Yeah, of course. My name is Jörg Heyer. I am here located in Hanover, and I am one of the recipients of one of the GROA projects right now. I like to point out and to be a little bit provocative. Please excuse this, but global health research and global health activities tend a little bit to describe in a very sophisticated way the problems. But we are still looking for solutions and for clinical solutions. And actually my point is that we need to include also to develop clinical solutions. What does it mean? We have to train people, we have to consider our descriptions, which are no doubt very important. But how can we develop clinical solutions, clinical processes, and to adapt to the environment in low and middle income countries, or even here in Germany? We have areas, and in all over the world, we have areas where our regular clinical processes are not working. And so how can we solve and how can we implement working clinical processes? And this is the kind of research that I felt very important, and all the projects that we have done during the last 10, 15 years always were successful if we included the clinical perspective, the process perspective, not just the clinical questions, but the processes, how to solve, how to act in the field. And this is actually something that I really want to advise. And I'm very happy that our project in GLORA at least could start with such a perspective. And so my hope is that we can find consortia who are willing and able to develop these things, to exchange experiences. So this is a kind of question: how can we include the clinical perspective and one perspective from our side? Thank you.
Yeah, and I think that's exactly where we need the interdisciplinarity, isn't it? And to understand how we bring clinical interventions, for example, into different contexts, different contextual settings. I do have a question though, a little bit. I'm gonna ask another question. And that speaks to the tension. I think that also Enrique had mentioned this. Do you feel comfortable in another discipline? And I think one of the very practical questions that people ask themselves when they try to build the field of global health, which is of course extremely interdisciplinary, is do we house people in their discipline? So in a way, you want the sharpest minds, right? So you want to keep them fighting fit. So do you keep them in respective faculties and think you create excellence there? Or do we create a discipline by having more multi-sectoral platforms, by having more sort of degrees where you have these really a wide range of disciplines coming together? So what is that a tension? Is it a fake tension? Do people have a view one way or another? How do we go if we want really to have interdisciplinary research that addresses the key questions in global health? So what's the right mix there? I don't know if someone from our panel wants to take that, or if somebody in the room or somebody in the virtual room.
I can start maybe to make a suggestion. So I quite like the concept of Duke University in the US, which have actually gone a way which could address maybe this problem. And so you can do a bachelor's and a master's for global health at Duke University, but you cannot do a PhD in global health. So they have decided that at least during this time of PhD, you should use to delve into your discipline, right? But then you come out again. But you do that after having a master's in global health. So you are trained interdisciplinary to a certain step. Then you sort of delve into your discipline, but then you come out again. And the other thing that, of course, in academia would help are joint assignments in different faculties for professors. So social science and life sciences. So we do that at technical universities. So we have joint appointments of individual professors, for example. So just as a kickoff.
Thank you. Some practical examples. Anyone else? I can turn to the outside.
Oh, sorry.
Oh, sorry. Should we take the lady from the floor and then we go?
No.
Hi, I'm Ella Sauerborn. I'm from the Technical University of Munich. I just wanted to mention that I think we can learn a lot also from looking abroad, like for example, in the UK context. For medical students, there is the option of intercalating, which fosters interdisciplinary education, as already been broached. The importance of interdisciplinary education, especially also for medical students, to kind of foster the next generation of global health minds. And that's not really the case in Germany at all. I find the medical studies are very, very clinical, and it's quite unwieldy. So I think what Germany could do would be to look to the UK or other countries and just pick ideas from what works for them.
Thank you. Very interesting example. And of course, some people in the UK say, oh, all our global health stuff is so biomedical because we've got all the intercalating medical students. But I think it is a good point that at present that route is not open, and it's practiced, I think, also in the US.
No, I know there are more people to intervene, but I just say that this idea of joint appointments, I think is a wonderful first step. Anyhow, it's very difficult. I don't know the situation here in Germany, but for instance, in my country, the schools are islands, and they don't want this sort of things, and it's even difficult to make joint programs. So we are in a phase we are building joint programs. And for instance, in Portugal, we have a global health PhD program that is very unique because it's from my university and a university in Lisbon. So with different schools, so we managed to bring people together. But then the problem is get funding, because it's difficult to show that there is a coherence and that the excellence is in all the pieces around, and some are better than others. So it's difficult to compete with other programs for funding. So it's that's why I would say it's a journey. I think it's something that we need to begin. But I think joint appointments will help to break the ice.
And going to Natalie, just as a last comment to take it out of academia again, what do you think in terms of the from perspective of product development?
No, I think what I wanted to say is that what we're trying to do is to build research capacity. So I don't know if you would call it global health, but it's bringing research capacity in the countries with very ambitious plans of training a lot of people that would, 600 to 1,000 per year. But the important thing is that research training is transferable to other issues in the country. And so we're not for, having hyper-specialized researchers. They can be also hyper-specialized, but it's more something that can bring them to a level where they can do any other research independent of working with DNDI, and that's the key thing, I think.
Gary, you had your hand up as well, and then we go to you.
Sure. Just to add that, don't copy anybody. Do whatever you need to do. Don't go after one or the other. But mainly also take the opportunity that to engage with another institutions globally. And whatever it looks like, will that be joint degrees with institutions in the South or exchanges or whatever it is? No global health program in Germany can do that, just integrate its own programs. It has to engage with several others in actual outside of Germany. So that'd be my advice.
Thank you.
Yeah. So we are coming to an end. We have heard and discussed different perspectives of WHO, the academia, and R&D on the question how to facilitate interdisciplinary and cross-sector collaboration for NTD research and control. This is not a new question, but I think it is worth to discuss this continuously in the context of changing conditions and changing situations in the area of global health. This is what we experience just now and during the last 2 years. For me, it was interesting to see the different views. I have learned a lot, and we have seen money is not is important, but other things are important as well. It's not everything. Data sharing, seed grants, capacities to build up, collaborations between institutions, and sharing visions. This is also important to bring the topic forward. Yeah, I would like to thank Glora that has made possible this session. I would like to thank all the speakers for their views and the lively discussion, and also the auditorium for the attention and also for the contributions for this discussion. Thank you very much.